I'm Keith from CureGrin, and welcome to our last formal session of the day. And this is called, this session is addressing what matters most. So today, Hillary from Grin Therapeutics is going to speak about their research and their patient survey about patient priorities and family priorities and other things. And I'm going to talk about CureGrin's GRI census. So the GRI census is something that we launched less than a year ago on August the 1st to collect data from our families and advance the search for treatments and cures. We have it available in 11 languages, and we have 2 more languages coming online later this year. So Arabic and Hindi will be the next 2 that we're releasing. We do we have scientific translators that translate it, and then we get families or researchers or clinicians involved in GRI disorders to double check it all before we send it out. This number might even be out of date by now, but when we closed off registrations for the data that we're presenting today, we had 441 people who had completed the census, and it's still open, so definitely encourage you to participate. So this is the kind of the pitch that we give about why it's a good idea to fill out the census. So this is an ethics board approved study, so we have to get everything like this, our recruitment material, approved by the ethics board. But basically the reasons for participating are 5. We think that there's 5 reasons that are good for families to participate. So the more people who fill in the survey, the more patients that we know that we have for each different gene, draws more interest from both researchers and industry, biotech and pharma companies. And it's also important to know the variants that are the most common. So we often get asked at CureGrin from researchers that are looking to develop a zebrafish or a mouse, what variants are more common? And so the more people that are enrolled with a particular variant could draw more interest for that animal model. It's also really important for location to be counted. When we've been able to, we've been trying to help Grin Therapeutics to know where we know that there are patients, because as they move forward and they're trying to pick sites for their clinical trials, they want to know where there are patients that we can help them reach. The symptoms will be counted, so we have a better understanding of the symptoms, but then we also have a better understanding of what symptoms matter most to families. And so that's a lot of what I'm going to talk about today. I mentioned that we had 440 respondents. About 114 of those we haven't included in the data that we've presented yet, that we're presenting today, because either the families didn't list a specific variant or the variants are listed as unknown significance in the databases. We've been able to go and work with researchers to move some of the variants of uncertain significant into the pathogenic category, so we've included them. We were especially focused on doing that with GRIA because we had smaller numbers of participants. And we're still working to try to get more of these in the category where we believe that they're pathogenic, so before we publish this data. So we're planning to put together a research paper that we'll publish. So that leaves 327 patient responses that we analyzed. And one thing that we've done for privacy and especially because we wanted the survey to be able to be completed around the world, in Europe, there's kind of stricter conditions about what kind of data can be shared out and what's considered re-identifiable. So one of the things that you will not see here is any gene or variant that has less than 3 responses we won't share. And so because of that, there is one gene, so GRIA4, once we just used the validated data that we could confirm was pathogenic, we only had 2 responses, so we're not sharing the data with that today, but we'll share the other data. So here's the total number by gene. So GRIN2B is the biggest population who's filled in the survey. GRIA4 is the smallest. Here's a breakdown by region. So the biggest patient population is in the US, North America North America is over half of the population. The blue is Europe, and the green is Asia Pacific. And the big part of Asia Pacific is in China. We've been able to make connections with researchers there who have helped us to spread, or researchers and physicians who have helped us to reach more GRIE families. And then this data shows the distribution by age. And so, can I get this handheld turned on just so I can be closer to the, thank you. So by age, you can see that basically as people get older, there's a smaller number of people who have, that we have in the census. So for people over 20 years of age, we only have 8 responses. So it's a very, very small amount. And we know that, the people over 20 are much less likely to have gotten genome sequencing or exome sequencing done. People over 30, there's almost none. So I know that there's, a few people here who have children who are in their 30s or even 50s, and so that's definitely is an exception. And we think it just has to do with when genetic sequencing became popular and the fact that people who are older maybe aren't being referred for that or just not being thought of when it comes for that sequencing. So we're presenting GRIE census data over 2 days, and so part of it is today in this presentation. I'm going to talk about data that we have on quality of life, on interventions and medications, and on patient and family priorities. And then tomorrow, our science director, Dr. Mara Cohen, is going to talk about symptoms and comorbidities, and she's going to really be looking at the differences and similarities among the different genes. So just in terms of quality of life, there are some kind of formal quality of life surveys with a lot of different domains that can get asked. We did something much simpler in the GRIE census, and we just asked parents, just based on everything for your child, what is their quality of life? And here's what the responses look like. So about 15% of people said that their child had an excellent, and when I say this, I say child, but there's about 5 or 6 people who were able to fill out the survey themselves. So there's some patient reported directly, mostly parent reported. And then about 36% good, and then about a quarter each for fair and poor. So because we haven't asked other questions, it's hard to know exactly why. We started looking at some correlation work with different responses, but nothing really stands out. But what's interesting too is when you look at the quality of life by gene, that there is a difference that the parents who think their kids have the worst quality or the toughest quality of life, you can see that GRIN1 has very few in the excellent category. GRIN2D has it's a smaller population size, but none in the excellent or good categories. And that sort of correlates to what we know about the broader phenotype for those disorders, that GRIN2D has a lot of epilepsy and can have other very challenging correlations. So interventions and medications. We basically had a list of all of the different kinds, and I'm sorry if it's hard to read, the different kinds of interventions, and asked families just first, what have you used with your child? And so you can see that physical therapy is by far, is the first one. So about 2/3 of families have used that. A little less than 2/3 have done speech, and then a little less than that, occupational therapy, which focuses more on fine motor control. And then medicines for epilepsy, it's about half of our population, which is probably about all the people that have epilepsy. And then GI challenges is next, again, about 50%. And then we also asked, if you've tried this, was it effective for your child? And so here's some data around that physical therapy is not only the one that was used the most, it's also the ones that families say actually benefited their children. So 71% of families who used physiotherapy said that it helped their kids. 66% for occupational therapy. We have a big other treatments category. We haven't analyzed the write-in responses for that yet. but there's some things in there that families definitely felt helped. Speech therapy around 58%, epilepsy or GI challenges is about 60%, and epilepsy as well. And then if you break it down by gene, I know this slide is really hard to see, so and we only have the 5 genes here listed with the biggest patient populations. But for GRIA3, they had medicines for epilepsy as the what works the best, about 71%, followed by speech and occupational therapy. For GRIA2, it's actually medicines for neurostorms that they put as number 1, with physical therapy and medicines for sleep next. GRIN2A had neurostorms first, followed by occupational therapy and vision therapy. GRIN1, physical therapy, medicines for GI, and the medicine for sleep. And GRIN2B, physical therapy, occupational therapy, and then other treatments. We also asked family to list medications that they believe have been helpful for their child. And then we counted up all of the responses. And I think I've got a list of the top 10 here, but any guesses of what will be here? What? Yep. So number 1 is melatonin. It's a sleep medicine. Miralax, which is a GI medicine. L-serine, which is something that specifically targets the NMDA receptor. Valproic acid is the number 1 for epilepsy kind of medicine. Perampanel and Fycompa, this is something that's often prescribed for epilepsy, but especially with GRIA gain-of-function patients because it's a negative allosteric modulator for GRIA. Another Keppra, another epilepsy medication. Clonidine and gabapentin, which clonidine we saw in the responses was used for both ADHD and neurostorms and sleep among our patients. Gabapentin, which is a pain medication, it's sometimes used for neurostorms. So that's the list, and the numbers there are how many times they were mentioned among the patients as medicines that worked. And so here it's just broken down by category. We've got a few more listed there under the medicines for epilepsy. But yeah, so there's kind of broken down by domain. So then the final thing that I want to talk to you about today is the top priorities for treatments and cures. And so we actually asked families, there were 3 open-ended questions where we asked families to list your top priority, list your second priority, and then list your third priority for treatments and cures. And so for this, what I'm presenting today, we just analyzed the number 1 response from families. And so you can see, sorry that the numbers are showing up in kind of weird places where it's hard to read, but the number 1 is epilepsy, followed by intellectual disability, speech, mood, and behavior. There's some things that are interesting here that are very prominent in terms of symptomology, but didn't show up. So for example, and maybe they did show up, sort of, but for example, we have gross motor. I think we had, so 8 families that said gross motor, and then 7 families that talked about motor issues unspecified. But one of the, fine motor didn't show up in the priority list at all, although it's something that we know is a challenge in almost all patients. It wasn't reported at all as a number 1 issue. The other thing that we wanted to look at is epilepsy is the biggest number, but it's also something that's only in roughly half of the patient population. So we wanted to look at what things look like for patients who either have or have had epilepsy, and for people who haven't. So in terms of people with epilepsy, it's about half that listed that as their number 1 concern or their number 1 priority for treatments and cures. So the rest, it's really a mix of everything else. And then for people without epilepsy, the number 1 is intellectual disability, and you can see speech, and then mood and behavior was the third most important priority in people that don't have epilepsy. Okay, so here is a list broken down by GRIN and GRIA. So very similar in the responses, and you know, when you look at the overall data, we have far more GRIN families than GRIA families in the community, far more GRIN families who have participated. So the GRIN list is much closer to the overall list, but epilepsy, about 26% of people with GRIN had that as their number one choice, followed by intellectual disability and speech. That's the same with GRIA, and then movement disorder came next, followed by developmental delay. So then the ones that were different is that feeding and GI was mentioned by about 5% of GRIN patients. It didn't show up on the GRIA list at all in terms of the number one priority. And then muscle issues was there as well for GRIN, and that's mostly people talking about low muscle tone, hypotonia in their children. I don't know this yet. We haven't looked at the age data, but for our publication, we're going to look at how the priorities change by age. I think we might find that muscular issues, because it's one of the first things that a lot of families recognize, especially if the child doesn't have epilepsy or doesn't have epilepsy yet, that we may see that that's a higher concern for parents of younger patients. Okay, so and then I just want to thank all of the families who have participated in the census, and thanks, we've had help with analyzing this data from Chan Zuckerberg and Combined Brain. Dr. Anna Falzer at Combined Brain is our PI on the project. And then we want to thank the 4 organizations that have partnered with us to generate responses to the survey: GRI UK, GRI France, GRI Italia, and GRIN Europe. Thank you.
Hi, everyone. Bound to not. Oh. There we go. Okay, I'm just going to set my little timer here so I don't run over time. I'm going to take bets on whether my mom calls in the middle of the... Okay, so for those of you who don't know me, I'm Hilary Savoie. I am the head of advocacy at GRIN Therapeutics. Many of you heard earlier this morning from our CEO, so you know that GRIN Therapeutics is a New York City-based biotech company that is developing investigational Radiprodil for the potential treatment of GRIN-related neurodevelopmental disorder with gain-of-function variants. My role as head of advocacy is to work with advocacy groups like Cure GRIN and families like yourselves to understand what your needs are, what you're thinking about, what you're concerned about, and to take those insights from all of you and bring them back to my team and make sure that we as a company are collectively integrating what you're telling us to the extent that we possibly can. I want to pause for a minute. My first 2 slides are going to take a little while because I want to give some context here to understand that this role, the role of advocacy, as Bruce talked about this morning, is really, really important to who we are as a company. It's very, very rare that a company has advocacy as a first hire when they're getting off the ground. And I always want to focus on it because I believe it speaks to who we are and how important all of you are to what we do. You're at the center of everything that we do. And on a more personal note, my background was in doing advocacy work like what Keith does. I had my own foundation, and I'm also the mom of a little girl, a young woman with a neurodevelopmental disorder. So this is really personal work for me. And today I want to talk to you about a project that we undertook that really demonstrates that relationship and how important it is. We undertook this last year in collaboration with the GRIN community to better understand your experiences of living with GRIN-related neurodevelopmental disorder And I am just absolutely overjoyed to get to share this data with you because this is essentially the first time it's being presented, and it's your data, right? So of course you should be the ones who are getting to see it. Okay, as many of you know, GRIN-related neurodevelopmental disorder, which includes GRIN1, GRIN2A, GRIN2B, and GRIN2D, is relatively recently defined. And while there has been absolutely a wonderful effort underway to better understand GRIN-NDD by many in the field, many people who are in the rooms that we're all in today, we collectively as a community are still really trying to understand what the natural history or the disease progression is in these disorders and the experience of the disease, and to Keith's point earlier, the priorities of families. There have been no GRIN-NDD specific clinical assessments established to date because there's significant challenges to even identifying, understanding, and measuring the key symptoms that you all are living with and managing every day, the impacts of the disorder, and including specifically those that are meaningful to caregivers and patients. So in this study, we paired up with GRIN advocacy groups in the design of the study, GRIN Europe and GRIN2B Foundation to help us actually design the survey that we undertook. And the study involved 2 phases. So there was first an online survey of caregivers in the US and Canada who were recruited with the help of Cure GRIN and GRIN2B Foundation. And then there were subsequent interviews that we conducted with families, about a third of the participants, to delve a little bit more deeply into some of the topics to make sure that we really understood that we were all talking about the same thing and that we were hitting the mark. The output from this project is something called a conceptual model. So it's basically the landscape of what the disease is, what are all of the symptoms, what are all of the impacts. And then we used that conceptual model to develop something that's quite novel and exciting, which are GRIN-NDD specific tools to use in our phase 3 clinical trial, which you're going to hear a bit more about that trial tomorrow from our CMO, Mike Pinzara. But this is really important, right? Because these are specifically tools that are about to be used in a clinical trial that are developed in conversation with your community. So before we get into what the data looks like, 3 key takeaways that I want all of you to keep in mind. 1, some of the stuff that I'm about to present to you, you're just going to want to kind of facepalm because it's really obvious, right? You live it. You're going to know, of course, I'm dealing with these kinds of symptoms. But I want you all to understand how important it is that we take the time to collect this information from you in a way that it can be compiled and understood by people who are working in the disorder every day. That includes team members that I'm working with at our team who are designing clinical trials, but it's also really important to help explain the unmet need in your disease when we're dealing with the regulatory bodies, for example, that oversee our studies. 2, this research helps us understand what we can and should measure in studies of your community. So just because you can measure something doesn't mean that it matters, and just because something matters doesn't mean that you know how to measure it. So it's especially important in studies like ours, where we're not only looking at patients who have seizures, where there's an established way to measure them, but also trying to look at other symptoms that patients are dealing with across the board. And 3, none of this research can happen without you. So when you're being asked to participate in these kinds of surveys, these kinds of studies, it's really important you do it. We know you're answering the same questions a lot of times, but everyone's asking the questions a little bit differently in order to delve into slightly different questions, although they may look the same on the surface. Okay, so let's get into the data. This is a look at who actually participated in the survey. So we've got 57 caregivers of 58 children in the US and Canada that completed the survey. A bit over half of the children had GRIN2B. About a quarter had GRIN1, and GRIN2A were about 15%, and GRIN2D nearly 7%. Patients were aged 0 to 18 at the time of the survey, with about 2/3 of the patients coming in between that age 4 and 12 grouping. one of the most important things to think about when you talk about a disease like GRIN is to understand how, first and foremost, how patients are even getting diagnosed and what that looks like. So what we found is that the path to diagnosis, we see that at an average, the age of symptom presentation was 12.7 months, and the first doctor's visit to address these symptoms after they occurred was about 2 months after that. However, the average age of diagnosis was 3.8 years of age. So I love this slide because when I presented it to my team, I say, there's something really important here, and that is that you all are doing your jobs really well. You're on it. You're seeing that something isn't tracking, and you're speaking up. The place that we're falling down here is that the medical care isn't yet stepping in and finding the answers that you need fast enough. So there's work to be done there. Looking at that data in a slightly different way, we can say that nearly 80% of the patients in the survey had symptoms before the age of 2. 75% of them were seen for those symptoms before the age of 2, but only 2/3 of them had a diagnosis before the age of 2. All right, looking now at the specialists and therapists that are seen. First assessment was typically performed by a pediatrician, and the diagnosis was typically performed by a geneticist. Not unexpectedly, and as Keith also just highlighted, there are a number of therapists and specialists involved in the care of the children in this study. So speech therapists and occupational therapists were seen by most patients, and they were seen weekly or more on average. So you can see that sort of mustard and yellow numbers, those add up to being seen weekly or more than weekly. I think actually really importantly is that 80% of the patients in the study were followed by a neurologist or a neuromuscular specialist, and of those, nearly 3/4 of them were seen more than twice a year. That's a huge amount of time to go, frequency to see your neurologist, and over half are being seen monthly. Right? So this, again, it helps establish the level of severity of this disorder and what you all are dealing with. And I know it can feel like when you're in it, you're just going through your daily life and this becomes normal. This is a very serious burden of disease, and the data bore it out. Oh, okay. So, shifting to look at the symptoms and impacts reported by caregivers participating in the survey, there are a lot of them. This is a listing of all of the symptoms reported by at least 17 caregivers, or 1/3 of the people who were involved in the study. These are all the symptoms, signs, and impacts that were reported by at least one caregiver in the study. So we don't need to spend a ton of time here, although we could probably talk about each one of these for ages. The takeaway here is really that we worked to try to have a view that was as comprehensive as possible, and all of these symptoms were then verified through that interview process afterwards to make sure that we didn't miss anything. Again, this is the world that we understand everyone is dealing in, and it's a lot. Okay, so as our clinical trials are not focused exclusively on seizures, but seizures as well as the broader manifestations of GRIN-NDD, and we are, or will be, I should say, enrolling patients with and without seizures. One of the questions that we had going into this patient experience survey, and actually similar to Keith's point before, was outside of seizures. So if we look at this patient population and we remove seizures as a symptom, are families struggling then, regardless of seizure or not seizure, are they struggling with similar symptoms and signs of the disorder absent the seizures? So in our survey, we had about a 50-50 breakdown in patients with seizures and without. And what we found was that the most commonly reported symptoms beyond seizure were really similar regardless of whether or not those patients had seizures. They were also very similar regardless of which which GRIN gene was involved. Okay, so they were still highlighting the same most commonly reported signs and symptoms. And we can see here under the neurological symptoms, mild to profound developmental delay is obviously present in a huge number of the respondents, gross and fine motor delays, under physical hypotonia, easily fatiguing, difficulty gaining weight. There was a bit more broadness in the behavioral symptoms. They were a bit more split. But sensory-seeking behavior, which I know we talked about in groups yesterday quite a bit, distractedness, inappropriate screaming, also rose to the top. Okay. We also learned that there were, not unsurprisingly to anyone in this room, significant impacts on activities of daily living, or ADLs, as well as communication and sleep. Emotional and social impacts were also felt by more than half of the participants in the survey. Importantly, we also talked to families about the benefits that they would hope to see with a potential treatment, which came out to the neurological symptoms, including developmental delay, were at the top of that list, communication difficulties with ADLs, physical symptoms, and behavioral symptoms were also very close behind. All right. So as a next step in the process, so we had the caregiver survey here, you can see with that, actually should have been N of 58 there, sorry. Caregiver interviews, N of 20, right? That's all of the interviews that we conducted. And we developed and verified that conceptual model that I showed. And then we spent some time thinking about, okay, what are the domains that we can roll these symptoms up into, right? To identify what are the key areas that families are talking about and wanting to see movement in. And we came up with receptive communication, expressive communication, gross motor, fine motor, and behavior. And what's important here is that these are then the domains that we will apply to that tool that I talked about, the CGI, the clinical or clinician global impression scale, which is a relatively simple tool to administer, difficult to create, but nonetheless simple for clinicians to fill out in the study, where they will look at the potential for change in any one of these domains through the clinical trial. And again, it's a really exciting thing because your community helped make this, right? And this is the tool that we will be, or tools that we will be utilizing in that phase 3 trial that's coming up. Okay, in conclusion, so this is qualitative research that demonstrated GRIN-NDD is associated with a range of neurological, physical, and behavioral symptoms that have a significant negative impact and require treatment from multiple specialists. Regardless of genotype, so which GRIN gene, or phenotype, whether or not the patient had seizures, caregivers identified really similar sets of non-seizure symptoms as the most important to treat, which emphasizes for us the need to address that broad spectrum of GRIN-NDD, right? Thinking about all of those secondary symptoms to seizure, which are actually very primary for all of you in your day-to-day lives. To address the unmet need for GRIN-NDD specific clinical assessments of symptoms relevant to patients and caregivers, the conceptual model identified these key symptoms and impacts for inclusion in these GRIN CGI tools that we will be using in that phase 3 radipril trial, which again, you can hear more about tomorrow from our CMO, Mike. And of course, I have to say thank you again. Thank you to Cure GRIN for giving us the opportunity to speak. Thank you to Lumanity, who is our partner in conducting this research. So if any of you participated in the interviews, that's who you were talking to, is our partner, Lumanity. Thank you to all of the participants in the study, and to GRIN2B Foundation, GRIN Europe, and Cure GRIN for everything that you did to help collaborate on this study. And again, I just want to come back to those 3 points that we need to ground ourselves in why this research matters and what to take away. the study's not possible without your participation. Studies like this never are, and really appreciate that. This research really helps us understand what we can and should be measuring in our trials, in your community beyond seizures, and that is absolutely invaluable. And 3, it really helps us quantify the very real unmet need that you all are living with and understand and experience every day as we're doing our work and moving our trial forward. So we're really grateful for these collaborations and proud of the work that we've done together over not just this project in the last year, but through our entire company's history. Our team is here. My colleague Alex is in the audience there. You saw our CEO earlier this morning. Our CMO is here and will be speaking tomorrow. Our head of medical affairs is here. Please, please come by and talk to us, say hello. We want to meet all of you. It's really, it's why we do the work we do. It's why we get up every day and get cracking. So please do not hesitate to say hello, and thank you again for everything. Okay. Podium or seats? Seats?
Sure.
Okay.
Question?
Thank you so much for the presentation. It's a lot of data, awesome data. I'm just coming at this from a slightly different perspective. I was curious, now that you've had time to review this data, is there anything on the back end that you wish you had additionally collected, in addition to all of this data that we see now?
Do you want to start?
If you have something, sure.
I think the funny part about this kind of work is always that you produce a ton of data and it's easy to start framing the next question that you might want to ask. I personally, and I think my team might agree, but I'll speak for myself personally, I actually really want to spend more time with the data that we already have before we start framing further questions, because it actually takes a long time to walk through it, to understand it. I'm not a scientist, right? So maybe if I was a scientist, I would be a little bit, feel a little bit differently about it. I come at it like a mom in many ways. But you ask different questions of the data that you have, and there's always going to be limitations, and there's always going to be something that you wish you asked. But in particular, I'm really curious to spend more time with the interview data and the quotes from the families, where they really get into, what does it mean when you say inappropriate screaming? What does that look like? What does that feel like? What does that do to your day? And so I guess my thinking is we need more time with it. Before I personally am ready to ask more questions. That said, it's overwhelming, right? It's a ton of information. It's a small data set. I mean, I'm looking at Dennis Lowell here. He's probably like, this is, it's just a couple of answers compared to the stuff that he's working with. But there's a lot of there, and I think there's a lot more to be done with that. That said, I'm starting to think about the next questions. Not quite ready to frame them, but that's maybe a non-answer, but I hope it's helpful.
So when we went to design the GRE census, we recognized that there was already a registry that had been started by academics. So research teams in Germany and in the U.S. had each originally started their own registries. Simon's Foundation has a third registry, and then now, although they're different ethics protocols, basically the German registry and the American registry work together, and those are very detailed questionnaires that can take quite a long time to fill out. We knew that we wanted to have something that was quicker, and we didn't want to be as detailed or as robust as those. Our focus was really this could be a starting place for families, and then we could feed them into the other surveys. So our goal was to have something the families could fill in under 15 minutes. I think we've heard from some families that it takes them 2 hours, and some that only spend 15 minutes. So it kind of depends on whether you have everything together already, I guess, when you go in to fill it in. So nothing really stands out as something else that we wish we would have added, because if it's not here, we know that it's in the other study, and so we're trying to bring all that, see how we can bring that data together.
Hi, I'm Lana Wong. My son does not have seizures, and when I was thinking about all the research being done, I was always sort of under the impression that most of the research is targeted towards those who are having seizures, the children that are more severe. And, since my child does not have seizures, that treatment options are more limited. That's just how my thinking has been. But what's interesting about the top list of issues, they're kind of the same whether the child has seizures or not. So now I'm beginning to wonder whether there could be potential treatment options for kids without seizures to deal with the top issues, intellectual disability and communication, as an example.
Yeah. So I can speak a bit to that and provide a little context to our approach to that. One of the reasons that we are, we've been working again with this community since our company was founded, and one of the things that we heard loud and clear on day one was, this is not just a seizure disorder, right? This is not a seizure disorder. There are seizures associated with it, but there is a very strong non-seizure phenotype, and those children also need help. And we heard that. We're also in the position that the investigational treatment that we're working on is a bit different to some of the others that have predated it in the space. The treatments that we've talked about the medications that are approved therapies that are used in GRIN. They're not GRIN specific. Our approach is a GRIN-specific approach, so it's sort of grounded in the underlying biology, and Mike will talk a little bit about that tomorrow, but because we're taking aim at the underlying cause of the disorder, our theory and our hope is that we have the possibility to have an effect not only on seizures, but on these other symptoms that stem from that underlying challenge, which is associated with NMDA dysregulation, right? And by taking aim at that, the hope is that we would be able to have an effect on the broader symptomology. As a result, we're asking these questions, right? Because we really want to understand what beyond seizures are important and what that looks like and how to possibly measure them. Because there is a lengthy history of doing seizure clinical research where you're doing seizure counts, which are more complicated than it seems on face value, but still there's an established way to do that. It's less established to understand how you measure some of these other symptoms. And so that's why we're asking those questions. But absolutely, loud and clear, it has been heard that this is not only a seizure disorder. There are many other manifestations of the disorder that require intervention and help, and we are very hopeful that that this is a potential approach to that. And again, Mike will talk a little bit more about some of the data that from our previous study that will help contextualize a bit of that tomorrow.
Okay.
Yeah, I think that Grin Therapeutics deserves a lot of credit for that because, as Hillary said, like people know how to track seizures and seizure improvements, but the other things, there's lots of ways to do it, but it's not as straightforward. It's not as proven. You have to convince the FDA that this is the right way to measure that other things are improving. So I think it's really great that they have the two cohorts. The other thing that's kind of a related topic is there's this term, developmental epileptic encephalopathy, and it's a set of disorders where, by the definition and what a lot of neurologists believe, is that within these disorders, the intellectual disability and these other things that come with it are as a result of the seizures. That's the strict definition of a DEE. But I don't think that that's really the case in our community for the most part. I think that they're connected, related things that happen because of what's going on in the brain. So I actually remember one of the first meetings that I had with Hillary, I'm like, I don't think, like for most of our patients, this is technically a DEE because I think that, you know, we know that the receptors are involved in learning and memory. And so I think that they're connected. And I actually think that's probably broader within the community as well. But the first time that I learned that's how neurologists think of our disorder and DEE and other DEEs, I was surprised.
This is, this is really great work and I think really important. And I just was wondering if maybe you can speak to, you know, a lot of these publications are really good tools, right, for when families go to advocate for different therapies or specialists. And I wonder, and it kind of goes back to your point about it's not just about seizures, and it's obviously important for how we're thinking of clinical development and clinical trials, but I wonder if you can talk to a little bit about how this publication could be used as a tool for today for families in advocating in different treatments and specialists too.
Yeah, I think it's one of the reasons that it's so important that, you know, sometimes companies and researchers and, you know, they do this research and then that never really gets back to the hands of the people who are the reason we are doing it and the reason we can do it. So yes, it is super important, and it's to that point, it's really important to have it in a digestible format also that isn't just the journal article that, you know, we hope some neurologists will read, but also something that is digestible for families and helps them explain in those contexts. So having, we often talk about sort of what's like a lay summary or an overview of the findings that can be translated. Also, even just development of infographics and things like that families can even just share on social media to help explain the things that are going on. And those are all on the table and certainly under discussion. So yeah, thank you, Sophia. That's perfect feedback.
Yeah, and that's important for us too. So in the next month or so, we're relaunching our website. And one of the things that we're doing is we're really focusing it on who's coming to the site. So there'll be, if you're a family member, a section for you. If you're industry, there's a section for you. If you're a researcher or a clinician, there's a different section. And so we're going to be taking all of this and presenting it in slightly different ways, depending on how the audience is. And but also want to empower families and get them the data that they can give directly to the caregivers.
So I just wanted to ask just a clarifying question about data and the surveys. That is the Grin Therapeutics survey and interviews, that's separate from the GRE census? And just a follow-up question kind of for Keith, that I think I've submitted my son's info for a number of different surveys and over the years, and I'm fully in support of that. And I'm just wondering if you'd clarify sort of what's out there right now that we should be aware of. I think I've done, it's Searchlight, and is there, just so I can check and make sure that I've submitted it to everyone where that I should, what's out there right now and what should we know about? Because I want to support and provide as much data as I can to people who are doing good work. And so what should we be aware of?
Yeah, so the three big ongoing surveys, so we talked about the GRE census. There's the Simons Searchlight. They're going to be presenting their data tomorrow. we've been working with them to build the case to expand it to more and more genes. So now the 4 GRIN genes are in there, and GRIA 1, 2, and 3 are in there, and I think GRIC2 is in there, the one that they're still not sold on it being connected to autism, which is their criteria, is GRIA 4. And then the third one is the one that has the biggest patient population, over 1,000 people, are in the what I call the Lemke or the Lemke-Benke registry. So Dr. Johannes Lemke in Germany looks after half the world, basically like Europe and Asia, and I think Africa. And then Dr. Benke in Colorado, he's got the Americas in his survey. Okay. Yeah, those are the big ones. There's other smaller ones, like sometimes researchers will come to us and we'll reach out to families. The other thing that through the GRI census, we said, will you participate in more research? So we're going to, as we're getting people to donate plasma or blood samples, we're reaching out to those families that said they want to hear more about research.
And if I could just add to that, like one of the really important pieces about being participating in these kinds of surveys and registries, they all ask slightly different questions for slightly different reasons. And so, if you think about what we were doing, right, is we were really trying to understand a very specific set of questions, whereas like the GRI census and the registries, they're asking not only a set of questions, but then they're also trying to understand where the patient population is. And so, as Keith pointed out, this is how you get counted. And so the more of them that you can be in, the better, right? And again, understanding that it can be a bit exhausting. And the last thing in the world a special needs parent needs is like another form to fill out. But these are forms that can, they can really help drug developers. They can help clinicians as they're looking for clinical treatment standards. They do a lot of work. So really appreciate your involvement in as many of them as you can do.
Hey, thank you for the work that you're both doing. Just as a follow-up to that, I think a lot of families are wanting and willing to fill out surveys. I think as lay people, sometimes it's confusing, like a GRIN Therapeutics versus a CureGRIN versus a Simon Searchlight. And sometimes I don't know, there are like follow-ups that are sent via email. I'm wondering, since there is so much beautiful collaboration that happens in this community, I'm wondering if that's somehow like a marketing messaging to get out to the families. Like if I could see what was going on clearly, like you listed them so well, and I don't even know what I've filled out. And so I think maybe some of that might be just informing us, like what is out there and what would be necessary and helpful for us to focus our attention. Because I think sometimes I just see them come through the inbox and I'm like, did I do that? Did I not? It's like hard to stay organized when there's a million things going on in our lives. So I think there are a lot of people that are willing. I think you might get a really better response rate if it were clearer to the community. Just a thought.
Yeah, that's great feedback. One of the things that we asked in the census is if we could follow up with the registry to find out. So if you've given us consent in the census, we're going to Dr. Benke and Lemke and asking them if you filled out their survey, if you're up to date, or if we can reach out to you to direct you back to them. But there's definitely more we can do. One other thing I'll mention is that there's something called the CRID, which is a unique identifier that each patient can get. And it's actually something that the family sets up, and only the family knows what their unique identifier is. Nobody else does. But it's something that we collect. It's something that's collected by, or you can collect with Simon's Foundation. And so there's going to be a point in time where we'll be able to sync up the data. Without knowing who you are, we can sync up the data and get an even better understanding of patients.
Hi, I'm Jan from Florida. My granddaughter has GRIN to be loss of function, and until the last last person asked that question, I kind of thought we were excluded from this, and we probably never would have registered because it specifically said for GRIN to be gain of function. So that's, I think, where some of us get confused, because my granddaughter, it's all, she's 11 and she can't do anything herself at all. Can't speak, can't walk. Well, she walks, can't use her hands purposefully, can't do anything. She's, it's all the developmental milestones, and other than, I don't see how in the world she can walk the way she does. It must be inherent, she likes that. But so we don't know what we should register for as far as all these different sites. We'd register for all of them if it thought it would help.
Just to clarify, for the survey that we conducted with GRIN Therapeutics, we were taking all, for the survey, all functional characterization, either gain, loss, indeterminate, or not specified. That was really to understand the disorder. For the clinical trial, that is gain of function only for that interventional clinical trial. So that's the case, and I'll let Keith speak to the census.
Yeah, the census is open to everybody with any of the GRI genes. So we have all of the ones that we know there are pathogenic variants, except for the two GRID 1 and GRID 2. We don't have anyone responded from that population yet, but for all of the others, we have patients.
Yeah, I just want to give a quick comment. So I'm one of those scientists who's looking at surveys and trying to make sense, trying to understand why some of the children are looking a little bit different than others, and what are the needs. And I'm doing this for many, many disorders, literally hundreds. And the questions you have about filling out these forms and the burden, you have already a hard life. Typically, it's like 300% of a human being you need to be to care for your children, and you have so much other responsibilities, all the stress and so on. I know it's hard, but if there's one thing you can do, just is fill out every survey as often as you can. With this grid, what Keith mentioned, even if you fill out the same form, you might answer certain things sometimes differently, and we can then look back and see, hey, if someone has a child who's 7-year-old, suddenly people answer this differently. And so there's a lot of work going on to combine things in the back from different resources. I'm actually flying Sunday to a meeting in Chicago where there are 70 scientists like me, where we just try to combine registry data with electronic health record data, with wearable stuff, with Apple phone stuff, and people think about monitoring things at home. But at the end, everyone realizes, every one of your children is very complex, right? And we have so little knowledge, but we have so much technology now. We try to bring it all together. And so I know it's really hard, and it's a lot to ask, and it's not a small deal, right? So it's very clear for every one of us. But if you have time, just fill that same thing out again. If you don't have time, it's fine. No one's blaming you, right? But if you have time, just in case, just do it again. There's the whole armies of scientists interested in this. And it's definitely looked at, and people try to make most of it. And we are really grateful for everything you do for your family and for the research. And if you have a few extra minutes, just do it again. This helps us a lot.
And I think to Dennis's point, there is a lot of collaboration that's happening. So, everyone who's just spoken, we all talk to each other, and we're all sharing information. We're all working as hard as we can to make sure that we're syncing wherever we can.